Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high-quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
This is Ike Ahmed.
And I'm Arsham Shaybani.
And we want to welcome you to GT the Podcast.
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
Presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to GT the Podcast. In this episode, Drs. Troy Gurney and Richard K. Lee recap their article, Pearls for Effective Laser Cyclophotocoagulation of the Glaucomatous Eye, which was featured in a recent issue of Glaucoma Today. Coming up, they make the case that transscleral cyclophotocoagulation, or TSCPC, is the most minimally invasive and versatile surgical glaucoma treatment currently available and should be considered earlier in the glaucoma treatment algorithm. They review proper TSCPC technique and indications to maximize effectiveness and minimize complications. We'll hear first from Dr. Gurney.
Transscleral cyclophotocoagulation is a laser procedure used to reduce aqueous humor production through ciliary body destruction and thereby lower intraocular pressure. With diode laser transscleral cyclophotocoagulation, an 810 nanometer laser system transmits energy through the sclera to the ciliary body via a handpiece placed along the perilimbal conjunctiva, typically with the patient under retrobulbar or peribulbar anesthesia. Two types of transscleral cyclophotocoagulation are currently in use, continuous and micropulse. This article reviews the use of continuous wave transscleral cyclophotocoagulation, which we currently find to be more reliable and effective than micropulse cyclophotocoagulation. Traditionally, transscleral cyclophotocoagulation has been used in eyes with low visual potential and elevated intraocular pressure refractory to hypotensive agents, and in poor candidates for invasive glaucoma surgery. With refinement of the technique, a paradigm shift in glaucoma management has occurred. Transscleral cyclophotocoagulation is now performed earlier in treatment algorithms, even as primary therapy, and for many types of recalcitrant and advanced glaucoma. We have had excellent results with significant safety and consistency in the treatment of glaucoma that is pseudophakic, aphakic, neovascular, associated with silicone oil after vitrectomy, associated with corneal transplantation, and more. We believe that transscleral cyclophotocoagulation likely represents the most minimally invasive and versatile surgical glaucoma treatment presently available. Transscleral cyclophotocoagulation offers several advantages. The procedure can be performed in the clinic or operating room, and treatments are titratable and repeatable. The risk of infection is minimal. There are no incisions, sutures, etc., when performed properly to avoid neurotrophic keratitis. A fast and comfortable post-operative recovery is also possible, as with any procedure. There are nuances to performing transscleral cyclophotocoagulation to increase effectiveness and minimize complications. This article reviews the technique we use for transscleral cyclophotocoagulation, with discussion of its indications in clinical practice with different types of glaucoma and stages of glaucoma management. The transscleral cyclophotocoagulation technique can be modified in several ways, mainly by adjusting the power and duration of laser energy delivered. To keep outcomes more predictable and reliable, we start with a power of 1250 milliwatts and a duration of 4000 milliseconds, referred to as slow coagulation. These settings are rarely modified. Power will be titrated down only if excessive pops are heard. Power is almost never increased, in contrast to conventional pop titrated cyclophotocoagulation technique teaching, which recommends increasing the power until an audible pop occurs. Anecdotally, two types of pops can be heard during transscleral cyclophotocoagulation, anterior and posterior to the sclera. The anterior pop is higher pitched, resulting from cavitation bubbles within an air or fluid pocket interface between the probe, conjunctiva, tenon capsule, and or sclera. The posterior pop is deeper and duller in pitch. This dull pop occurs when excessive energy is applied to the ciliary body, causing an implosion of the ciliary body. This can be highly inflammatory and painful in the postoperative period. It is crucial to listen that the laser energy is applied for the entire 4-second duration and take care not to lift the probe from the eye or foot from the pedal too early. The probe delivers only 4 seconds of energy as dictated by the settings, so we recommend leaving the probe on the eye and foot on the pedal for an additional 0.5 seconds for each application to ensure complete treatment. Uniform positioning of the handpiece or G probe on the eye helps to maintain consistent energy delivery. The handpiece should be placed perpendicular to the sclera, not vertical or perpendicular to the ground unless the eye is rotated. The handpiece should be placed with all 4 corners of the footplate against the globe. The shorter edge of the wedge-shaped handpiece should be anterior, facing the limbus. It is essential to have a wet interface between the handpiece and globe with either balanced salt solution or hydroxypropyl methylcellulose as a coupling agent. This interface may need to be reapplied several times during the procedure. The handpiece should be coupled to the surface of the eye, so any pockets of fluid or air between the handpiece and sclera, example from chemosis from the anesthetic block, are squeegeed out before treatment. The Randolph cannula, which is a blunt and flat and typically found on the assistant's balanced salt solution bottle, is a useful, stiff tool to squeegee out any subconjunctival fluid to ensure proper coupling of the handpiece and sclera. We currently apply treatment circumferentially around the limbus while avoiding several key areas. The first areas to avoid generously are the 3 and 9 o'clock positions. The long ciliary nerves, which are critical to corneal sensation, tear production, the blink reflex, and corneal epithelium structure and function, are located within these clock hours. Damage to them can lead to neurotrophic keratitis and ulceration, especially in patients who are predisposed, whether due to medicamentosa, dry eye, a history of corneal transplantation, etc. It is also advisable to avoid areas of scleral thinning and areas of prior glaucoma surgery, for example, trabeculectomy and tube shunt surgeries. Transscleral cyclophotocoagulation energy applied in these areas can lead to excess energy delivery, conjunctival and scleral perforation, and complications related to prior surgeries. The handpiece should be placed approximately 0.5 millimeters posterior to the limbus. Transillumination of the globe can reveal the location of the ciliary body in abnormally short, long, or pediatric glaucomatous eyes. A handpiece placed too anteriorly can result in complications, including anterior chamber cavitation bubbles, hyphema, especially in neovascular glaucoma, segmental mydriasis observed during the laser treatment, and severe inflammation with fibrin formation, which will require prolonged treatment with anti-inflammatory medications. After each application of energy, the handpiece should move the distance of approximately 1 footplate for adjacent subsequent applications. Consecutive applications placed too close together can result in increased inflammation. After 360-degree treatment, random quadrants can be retreated so that an adequate number of appropriately spaced applications are applied. We typically perform 22 to 26 applications per transscleral cyclophotocoagulation procedure. However, the number of applications is multifactorial based on the level of IOP elevation, number of glaucoma medications, race, sex, age, and prior glaucoma surgeries. As with any surgical procedure, transscleral cyclophotocoagulation results in postoperative inflammation, and many of its complications result from excessive or untreated inflammation. We therefore recommend aggressive and prolonged anti-inflammatory management following transscleral cyclophotocoagulation. Intraoperatively, a subconjunctival injection of dexamethasone at 4 mg per milliliter is performed. Occasionally, a subtenon's injection of triamcinolone is performed in patients prone to severe inflammation. On postoperative day 1, prednisolone acetate 1% is started, with 1 drop instilled every 2 hours while awake in the operative eye. This is continued for 3 to 4 weeks and then tapered slowly every 2 weeks until cessation. If the probe was placed too anteriorly to the limbus with the aforementioned complications, for example, hyphema, cavitation bubbles, etc., then steroids can be administered every hour. In addition, a topical NSAID, for example, ketorolac, diclofenac, or nepafenac, is started with 1 drop instilled 4 times per day in the operative eye to minimize postoperative cystoid macular edema. This regimen is continued for 3 to 4 weeks and then tapered slowly every 2 weeks with a topical steroid. Patients who are prone to inflammation, for example, those who are aphakic, are younger, have increased pigmentation, are black, or have uveitis, may require a longer duration of steroid treatment, for example, a drop tapered every 3 weeks. Those who are phakic should be counseled on the possibility of cataract progression after transscleral cyclophotocoagulation. Given its safety, efficacy, and reliability, transscleral cyclophotocoagulation should be considered earlier in the glaucoma treatment algorithm, including as primary therapy. Transscleral cyclophotocoagulation is a conjunctiva-sparing procedure, allowing it to be used before or after more invasive glaucoma surgeries when viable conjunctiva is lacking. It is also versatile and can be performed in eyes with different types of advanced and refractory glaucomas and in conjunction with cataract surgery. Transscleral cyclophotocoagulation is a relatively efficient procedure with a fast postoperative recovery time. It can therefore be performed in nearly any patient population, including those who may be more difficult to manage, such as pediatric and elderly patients and patients with disabilities, cognitive impairment, or a history of poor compliance. Transscleral cyclophotocoagulation is titratable, allowing repeat treatments to lower intraocular pressure as needed. Additionally, is it a cost-effective procedure, owing to its quick duration and ability to be performed in the clinic and operating room, the minimal follow-up visits, and a reduction in costly glaucoma medications. With these benefits in mind, we believe that transscleral cyclophotocoagulation likely represents the most minimally invasive and versatile surgical glaucoma treatment available.
This is Dr. Richard Lee of the Bascom-Palmer Eye Institute. Dr. Troy Gurney gave a wonderful overview of some of the practical pearls for effective and reliable use of continuous wave transscleral cytophotocoagulation laser for the treatment of glaucoma. Although there are two different approaches to cyclophotocoagulation laser currently, mainly the micropulse and the continuous wave, we have focused on the use of continuous wave cytophotocoagulation laser because it has the most evidence-based medicine, mainly produced through our research, that demonstrates continuous wave transscleral cytophotocoagulation laser is among the most reliable, effective, and safe approaches for laser surgery in the treatment of both primary and secondary glaucomas, especially for refractory glaucomas that are not amenable to other types of incisional glaucoma surgeries.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.